Better Buildings for Humans is powered by Advanced Glazings, makers of the Solera line of products. Solera is the leading glass glazing made specifically for architectural daylighting and with extreme insulation performance. Learn more at advancedglazings.com. Hello and welcome to this week's episode of Better Buildings for Humans. I'm your host, Joe Menchefski, and this is the podcast where we talk about the impact that the built environment has on our health, our wellness, our productivity, and our general joy of being alive. And of course, we have to talk about sustainable design as well. Today, I have a special guest. I have to step back a little bit. I have to tell you about the early days of the podcast when we were first conceiving about where this was going to go. And, there's a lot of podcasts, a whole lot of YouTube sites, a whole lot of social media discussing the impact of food on our health, the impact of medicine on our health. But there just wasn't enough people having a conversation about the impact that the buildings that we spend 90+% of our time in was having on our health. And I stumbled across Tim Rossi, today's guest, who is the founder and the CEO of Architectural Medicine. What a perfect alignment with the objective of this podcast. And I'm so happy that I finally get to speak to Tim today. Tim, welcome to the show.
Joe, thanks so much for having me.
Yeah, it's an absolute pleasure. So look, the first thing I like to do, Tim, is I always give our listeners a chance to learn a little bit about our guests. Tell us about your background and tell us about the road that led you to create Architectural Medicine.
Yeah, Joe, great question. First of all, I've listened to a lot of your podcasts. Terrific work. I really learned a lot and enjoyed a lot of the discussions that you've had. And I will say that many of your guests have had unorthodox paths and journeys to where they currently are, it seems. And I will consider myself amongst those people. I'm a child of the 70s and the 80s and growing up just outside of New York City and in the USA in the 70s and 80s. A lot of the big topics for us growing up were the energy crisis and environmental topics. And of course, all the topics that came out of the awareness of the 60s. And I was very interested as a kid in building things. And in school, I just loved drawings and I loved the idea of the built environment. And so I went to school to study architectural engineering. And I found at school that many of the topics that I'd been thinking about as a kid growing up were either not taught, or really when I had questions of things like what is environmental design, I surprisingly had one response from one professor, which was, well, actually, if I asked if there was any courses, and they said, well, we have this course on asbestos abatement and management, which of course was not exactly what I was thinking of in my mind, but it just gives a sense of the mindset of that time and also how it differed. And so when I moved on from college and went out into the world of building and construction, I kept my interest and I became really fortunate in the 90s. I learned a lot working in the world across the country and then eventually with our friends over in Europe, where I learned a lot about what now we define as green building, sustainable building, and of course, healthy building. And I worked and learned from a lot of the pioneers of this work, and I feel really grateful. And that led me in the late 90s to co-form with a group of like-minded people, a startup that we were interested in, how can we get this information out that we've learned to the public? And we were a little ahead of the curve. This is before YouTube and any of the, online teaching methodologies that are so common today. But essentially, that's what we were striving to do. And long story longer, I essentially found myself after the first decade of the 2000s, still striving to find the solutions and, where I fit in all of this. And essentially in 2010, I found that a lot of the things that I've been studying were both the concepts of architecture and the topics of medicine. And I found that they were both the foundation of many of the topics that I was interested in and also the umbrella. It seemed everything kind of fit within that for me. And that basically became the origin of architectural medicine.
All right, well, let's do a deeper dive on that. Let's talk about the meaning of the term architectural medicine. Why did you choose that name for your company?
Yeah, it's a good question. And for me, I had been working in the healthy building field and realm for many years. Had some really terrific teachers that I just had this, knowledge that I felt like should be out in the world. I found a lot of the people that I learned from were doing their own thing in their neck of the woods, which of course vernacular architecture is terrific. And you need to have those pioneers, working in their kind of somewhat isolation, especially before the internet and YouTube. And essentially what I found was I knew healthy building, this kind of framework that was typically built on the idea of how the built environment was impacting our physical body. But I was also very fascinated and interested in the emotions of how we are impacted in the built environment and also our mental and psychological, approach. And I found that if I went with healthy building, it seemed like it already had a definition. And the concept of architectural medicine is the larger picture. How our building affects us physically, emotionally, and mentally or psychologically. And I've found that many of the terms, even in green building and sustainable building and healthy building, had different definitions depending on who you were speaking with and where in the country you were, where in the world you were. And I felt like architectural medicine gave the ability for these topics to have a larger scope and to be all encompassing and not limited in, kind of scope in terms of kind of reviewing these things, but also making sure that many of the topics that I had interest in that maybe were not being as much of a focus could be encapsulated in that.
Oh, I like that a lot. All right, I'm going to go off script a little bit because I have to. You talked about some of the topics that you're interested in. Could you list, say, three or four of the topics that really, were important to you and inspired you to make some changes or contribute to some changes?
Yeah, I think, many of the studies, so this is really where the healthcare part of architectural medicine comes into play. And in the 90s, there was some discussions amongst doctors and people in the healthcare profession that were concerned about how the building was impacting our health. And to give you a perfect example, this startup that I was a part of in the late 90s and early 2000s, we were based in Los Angeles. And at that time, in the late 90s, mold was becoming really an important topic. But across the country, mold at that point was almost seen as silly. People thought, oh, that's not, of issue. And how could that impact our health? And so there was a perfect example of how many people that our group were dealing with who really their health was being impacted tremendously with these mold issues in their buildings. And so it was a perfect example of this is a topic that is not currently at that time popularized. But we knew that with many of the concerns that were moving forward, that these were going to be issues that were going to be on the builders' concerns and the architects' concerns, where it was coming from the healthcare perspective. And that's a perfect example from my experience of where these topics of concern by people in the built environment who are focused on emotional, mental, physical health, we're looking really at the physiology of how these issues were impacting people. And another perfect example is VOCs. In the 90s, again, this was a topic that was coming out of the 80s where asbestos and lead paint, and even I grew up in a time, which you and I both grew up in a time where lead in gasoline, was the norm. And so these were things where they were not on the radar of the mainstream, but they were basically being important factors in the trajectory. And so these indoor environmental quality issues were becoming more and more common, but really were not popular in the kind of mainstream architecture scope.
Oh, for sure. Yeah. I mean, it wasn't until 99 that, Lisa Heschong's studies started to be published and become popular with regards to the impacts of natural light on our ability to learn and multiple impacts. Has daylight crossed I have to ask that. Is
Yeah,
daylight part of your world, Tim?
it is. So, lighting in general has such a big impact on us. We, of course, I know you're deeply involved in this field, and I've learned quite a lot actually in many of your podcasts and those discussions. You can't, and this is actually something that I will comment on with architectural medicine. In my first book, Architectural Medicine, I took the time to provide an overview of many of these topics because the way that I have learned these topics has been kind of piecemeal. So I learned a bit of green building, I learned a bit of sustainable building, I learned a bit of healthy building. I was lucky enough to work with people who saw the big picture, but most of the people that I was learning from, it was, kind of piece by piece. In my opinion, though, you cannot separate them. You cannot separate daylighting from noise issues, from thermal comfort, the IAQ topics. All of these have to be viewed as a cohesive whole because we are cohesive beings. And if you try to separate and look at one piece of these topics, I find that we actually will get into more trouble sometimes by focusing on one facet where, oh, we've solved this problem, but we've created many of the other problems that we didn't factor into that equation because we're not looking at it from the whole picture. And this is why daylighting and lighting and all of these topics that I would consider, indoor environmental quality topics to be paramount.
I'm so glad you talked about that balancing act. That's, as you know, that's near and dear to my heart. So lovely that you brought that up. It's so important. Yeah, in our zeal, sometimes and our desire to do what's absolutely right, we overdo one aspect and, at the suffering of another aspect of creating a comfortable, healthy space.
Exactly. Yeah.
Yeah. All right. So you and I have talked a bit before we finally got to record this episode, and you introduced me to some new ideas. Let's talk about some of the definitions. And this one really caught my eye, the word exposome. Can you explain what exposome means, why it matters so much?
Yeah, Joe, to me, this is a perfect example of what we were just talking about, where you have many different facets and many different professions that are focused on the built environment from their viewpoint, right, from their perspective. And what I find fascinating about the exposome is it's essentially, the term itself is based on exposures. And, a definition is basically describing the environmental exposures that an individual will encounter, over their lifetime and how these exposures impact their biology and their health. The concept itself began from Dr. Christopher Wilde in 2005. And so it's not a new concept, relatively speaking, but at the same time, it's become more and more popular and more common in the medical fields. And what I find fascinating about this is that when you're looking at how a person over their lifetime has been exposed to environmental toxins or any kind of environmental pollutants over their lifetime, how can that be measured? How do you go about measuring that? And the medical field is just beginning now to view that and to do some data science analysis. There was a great video on YouTube that I came upon about a decade ago called What is the Exposome by Dr. Stephen Rappaport of the University of California in Berkeley. And what he said was that he came into this field as a geneticist. And he found that after decades of working to try and find the etiology, the origin of many diseases, he found that they were still 2/3, 65 to 70% of the origin of diseases is unknown. And the genetic impact seemed to only have about a 5 to 10% impact or knowledge on diseases. So if there was only a 5 to 10% impact on genetics with the origin of disease, what's the rest? And so many scientists now and healthcare professionals now are really beginning to question, this impact of what's the origin of disease and how can we approach these and how can we approach the knowledge that there can be a better approach. And so this is where the exposome comes in, right? It basically is evaluating the environment and all of the myriad, whether it be air quality, Z codes, of course, is a big topic if you talk to people in social determinants of health. what are these determinants that are impacting people's health? And there's a lot of overlap between social determinants of health and the exposome and how we spend our lives, especially in the modern day age. 60 to 90% of our time is spent inside. And yet the medical field has very little knowledge of how their patients are being exposed in their built environment. And that is something that where the exposome is really coming into play with these topics.
Yeah, it's huge. It's not a term that we hear every day, but it really should be because, these things have to be all encompassing. We've sometimes, well, I'm thinking back to science in high school and we were trained to isolate the variables. And then, when I got out into, well, I'll say the real world, you recognize that isolating the variables is a huge mistake. The first example I saw was drinking and driving. Right? The probability of death for having a few drinks is very low. The probability of death for going for a drive in your car is very low. The probability of death when you put the two of them together is very high. And it sounds very simplistic, but it's not the way, we used to practice science and engineering. We tried really hard to isolate those individual variables. And as it turns out, that was a mistake.
Yeah, I think a perfect example that was a seed that was planted for me decades ago was when I did take that course on asbestos abatement and management in college. And I realized that asbestosis as a carcinogen, when you add that with cigarette smoke, exponentially has an impact, right? And so that's an example of you combine those two things, you look at one facet, you recognize, okay, there's a major issue here, asbestosis as a carcinogen, but you add in other elements in there, other exposures. And now you have, this conflated topic where you really exponentially add to the negative impact. And these are topics that, it's very common that, like the World Health Organization, for instance, will comment that indoor air quality can often be 4 to 5 times worse than outside air. And if you're in an urban environment, the outside air may not be that good to begin with. So that's a perfect example. How is that impacting a person's health? And over time, whether it be a direct acute issue or chronic, these are factors that the medical community is typically not adding into their evaluations.
Do you want to bring lots of healthy, beautiful natural light in your building and still meet energy codes? Try Solera from Advanced Glazings. Learn more at advancedglazings.com. Yeah, absolutely. All right, there's a bunch of stuff I want to cover, so I'm going to move on. We could talk about just that last topic all day. But okay, building informatics. You've talked about building informatics. I think most people would know what that means, but just to be sure, can you define what it means and talk a little bit about how the collected data can be useful in keeping us healthy?
Yeah, it goes right in line with what we were just chatting about, right? You have these evaluations and these exposures. And, informatics, for those of us in North America, we define it a little bit different than people in other sections of the world. I'd like to note that because I make sure that we're global citizens and we want to look at the bigger picture, including how everybody views these topics. And so for us in North America, we defined informatics as essentially the science of how to use data and information to improve health and the delivery of healthcare services. That's the official definition by the American Medical Informatics Association. And when you look at many of these topics that they're defining with informatics, so there's clinical informatics, there's public health informatics, biomedical informatics, all of them are specified for what realm they're working in. And what I found is that if you don't have a topic of building informatics, where you're using data that is involved in the built environment focused on health, then we're missing out on an opportunity to add to the healthcare processes, right? We all know that the field of architecture and the field of medicine, they are very complex systems. They have procedures and processes and codes. And if you try to, provide ad hoc solutions to any of these professions, you're going to find that it doesn't really go very far, especially when you're in terms of scale. So building informatics is that term that I use, and it's a term that other people are using out there in the world as well, to kind of focus on the data science of building data for our occupant health.
Yeah. Okay. Fantastic. All right. We have to talk about your ARXmed platform. Okay. Tell us what the platform's all about, how it works, what you're hoping to achieve with it.
Yeah, thanks for asking. So ARXmed is the architectural medicine software solution that, building on what we were just talking about with environmental exposures and building informatics, where the use of data could be evaluated in a built environment focused on occupant health. In the time that I'd been learning many of the processes over through the 90s and into the 2000s, I worked with a number of inspectors, and they were consultants that were focused on how they can evaluate a building, not just in terms of the structural integrity, which of course is critical, and all the other facets that a typical building inspection entails, but adding into it a focus on occupant health, the indoor air quality, VOCs. There's a whole lighting, right? Sound, all these topics, they need to be evaluated. The challenge is there's not really a process in terms of recording that data and then utilizing that data to help with both the occupant and any other professional that needs to be involved, right? So if you take that building inspector and you advance them in terms of their viewpoint with the focus on health, I define that as a healthy building inspector. And that person and that process of going out into the built environment and doing evaluations requires a platform for that information to be recorded. So that's part of it. The bigger picture of the ARXmed platform is that it's not just the building inspector, this healthy building inspector that's involved. It's how do we involve the medical community, the doctors? How do we include the architects and the builders? Because the ideal situation is that a medical doctor is including the built environment in their patient's analysis. And in order for them to do that, they need a platform that integrates with all of the other professions. And I created a flow chart of this called the architectural medicine system, where it's essentially a flow chart of the doctor, addressing these topics and saying, do any of these ailments or conditions, maybe it's a respiratory condition, maybe the built environment is impacting their health. But there's no way right now, at least, and there hasn't been, for a doctor to provide those evaluations. And so the ARXmed platform helps with both recording this in inspection processes, but also helps to integrate these professions so that a doctor can request a healthy building inspection and then receive that data in a way that obviously the electronic health record is critical for them. To expand on that, there's the comprehensive health record, which includes social determinants of health. And essentially, a building inspection that's focused on health could also be included in that data. So it's kind of a bigger picture view of a platform using the benefits of our software in the modern day world to achieve those goals.
That is absolutely brilliant. I have never even heard of a doctor asking a patient anything about, where they work, what, like, other than coal miners, maybe, there's somebody working in an oil refinery, the doctor might think to ask, but beyond that, it's just not, it doesn't come up. It's fascinating. And it's such an important aspect of our health, as we know. Yeah, but I've never made that connection before, that the doctors just don't, it's not part of the troubleshooting process or the diagnosing process.
It is one of those things where I think many people would understand the concept. The question is, well, how do you do that? How does a medical doctor become involved in that process? And again, going back to the comment that I made previously, the field of architecture and the field of medicine, these professions are incredible people. They have spent a lifetime learning very complex, sophisticated topics. They work with very complex systems to begin with. I learned in the 90s that when you try to provide ad hoc solutions that are not within those systems, of these professionals. They either like the idea and want to try and implement it into their world, but let's face it, as you know directly, architecture, it's just such a very complex field. If you don't provide systems for them and include that in their training as an architect and as a medical doctor, then the scalability of these topics is not really going to have much of an impact. And I learned that in the 90s because I saw a lot of people who were doing consulting on these topics. They burnt out. They would have to educate everyone on everything, and including their clients. And it was just too much. And so I learned that these systems, if they can be implemented and integrated within these professions, and with the addition of a healthy building inspector, focusing on things that you and I are both concerned about, daylighting and sound and noise and indoor air quality. And there's a plethora of topics that need to be evaluated that the medical doctor and the healthcare professional could utilize in terms of where this person spends, 60 to 90% of their life within, and is completely not being included in that picture of analysis.
It just struck me while you were speaking there, like one of the most fascinating things about architecture is that it crosses into so many other areas of study. The obvious one is art, but there's also sociology, there's anthropology, there's politics in some way, there's engineering, and there's medicine too. And so, yeah, it's becoming a more and more complicated and fascinating field of work. So I love this conversation. All right, we got to talk about the architectural doctor. You referred to it just a little earlier, which is a book you wrote a couple of years ago. Are there any big ideas in that book that I should have asked you about that we should be talking about? I'm sorry, I did not have time to read it, so I apologize. Yeah. It's on my list, but I just couldn't pull it off. So is there anything there that what are the big ones that I missed by not having the chance to read it yet?
Yeah, Joe, thanks for asking about that. So when I wrote my first book, Architectural Medicine, my idea was, how do I provide context for, a big picture view? And the second book, the Architectural Doctor, is focused on how do we get into the details? And what is the architectural doctor? The idea of a professional who can span and bridge some of the gaps that exist between the worlds of architecture and the worlds of medicine. And it's interesting, Joe, before COVID, when I would talk to people about health in the built environment that was not just physical health, but emotional and mental health, many people would look at me kind of quizzically and say, what do you mean? How does my built environment impact my emotions or my mental health? And whatever stage of COVID that we're at now, when you ask those people or make that comment, people immediately respond and say, oh yeah, I spent 100% of my time inside for a year or more. I have an understanding of what you're talking about. And I use that topic because the architectural doctor is in a similar kind of format, where I used to talk about this type of professional who would be well trained in the field of architecture and well trained in the field of medicine and healthcare, and help to provide those integrations. Which, if we look at COVID and we look at the knowledge during COVID that the medical fields were providing for us as a general public, the challenge was how that was the architecture world, in the building world. And it clearly, for me at least, showed the gaps that exist between these two worlds. And there is essentially this concept of a bridge between these two fields that can help provide those topics that both the architect and the doctor need to understand, but they're already, spent a lifetime with one of these topics. They can't learn both. And so bridging those gaps to help with those integrations, so that the idea of the doctor having a professional that they can have better insights and better integration with their knowledge for their patient's health, and the architect who may want to provide their occupants with a better sense of healthcare and health, but not just in a hospital setting, right? I mean, all of our built environments should be focused on in a healthy format, and not just an architect who is working in the healthcare profession. So that's essentially what the architectural doctor is focused on, these topics that we've been talking about in terms of environmental exposures, building informatics, and how that professional can really help synthesize all of that information to help each of the other professionals as well.
I love it. Does the book get into connectivity at all, Tim? And I mean connection to the natural world, the views out the window, the natural light coming in, the fresh air, views to biophilic, to plants, to
Yeah.
animals. Do you have a discussion on connectivity in either of the two books?
Yeah, I love that question, Joe, because I do actually talk about that topic with what I think and many other people would say is the origin of evidence-based design, and that is a study in 1984 by Dr. Ulrich, where he basically had his famous research, view through a window may influence recovery from surgery, right? He had one group of people who had the view of a brick wall, and he had another group that was viewing nature. And it found that this information was really valuable from a knowledge base perspective, in that the people who had that view of nature, right, that biophilia experience, had a reduced amount of time that they spent in the hospital post surgery, and also a reduction in painkillers, or any kind of pharmacological benefit that was required. And that really became a huge impact on, I think, perspectives in how people viewed impacts and exposure to nature, right? We have the biophilia impacts and the importance that we know today, and how that can be so important. Healthcare and the architecture field with healthcare is very involved with this topic. And, if you're involved in architecture, you know that. But what about all the other places that we work and live? These should be as equally focused on in terms of the importance of these topics. And that's where I do talk about that in my book. And I talk about, many of the other topics of how biophilia impacts not just our physiology, but our emotional and our mental, psychological health. These, to me, going back to your comment before, where you can't just separate them, right? They have to be looked at from a bigger picture and a cohesive format. Because if you separate them, you end up missing facets of us as humans that could be critical with our health.
Manage the connection between building occupants and the outside world using Solera translucent glass. Learn more at advancedglazings.com. Yeah, absolutely. I'm glad we got to chat about that. Now, I want to talk, I'm going to change gears completely on you here. You have an interest in neuroarchitecture, and we've dabbled about that through much of the conversation. Rapidly growing field, rapidly maturing field. Are you working with the principles of neuroarchitecture? Are you working with the principles of neuroarchitecture? And if so, how are you weaving that into your work?
Yeah, it's a great question. I'm fascinated by neuroarchitecture for a couple of reasons. I read this paper by Dr. Moshe Bar. I think it was published in 2007, 2008, where he was doing studies in terms of how people were being impacted by shapes, forms, textures, and especially where there were shapes that were very angular and, maybe piercing in some ways, sharp edges. And when I was reading his research, it showed that doing these studies and these evaluations, they're using the technology of fMRI, right, which is the ability to see in real time what the status and the activity of the brain is. And what he found was that people who were viewing these images with these sharp angular formats had a lot of brain activity in the amygdala. And that's the section of the brain that is the fight, flight, or freeze. And what I think is even more fascinating is that when he was discussing this with the people who were viewing these images, it seemed like people did not recognize that they were under any kind of duress. And what it made me recognize is that there could be environments that people are navigating every day, where their nervous system is under a certain amount of stress. And of course, going back to the WHO, World Health Organization studies earlier that I mentioned, stress is within the top 10 impacts on disease and death. And so when we're looking at many of these causes of these diseases, I think this is where neuroscience becomes fascinating, because we can recognize views of how we navigate our lives and how we may be exposed to stressors that we may not have factored into the equation. And I think this is where neuroarchitecture can both be so positive in helping us to understand how our environments are impacting us, especially when it comes to these stressors, right? If we're under that stress constantly and we don't recognize it, or we're kind of numb to it over time, our built environment could be impacting us in that way that we're not even aware of it. And so this is where the emotional and the mental or psychological component of the topics that architectural medicine is kind of focused on really comes into play. And it's evidence-based design, right? Which is hugely valuable. You can actually measure these topics and utilize that moving forward. So that, again, that integration between the medical community who's doing that research can help with the architecture professionals in iterating these to provide spaces and places that are less stressful, more enjoyable, and provide better health and wellness, right? And so this is where I think neuroarchitecture is really exciting.
Oh, I love that. Okay, Tim, it's time for the $1 million question. So as you know, there's a question that I ask every single guest, and I ask them to answer it from whatever perspective they'd like. What makes a great building?
Yeah, Joe, like many of your guests, I'm going to say that's a hard question. But I think about some of the things when I was growing up as a kid, I was sensitive to spaces, which is another reason why I was intrigued with architecture. I picked up on places that I felt comfortable in, and whether it be too noisy or too hot or too cold. And I seemed to have a very visceral response to that, which when I went into architecture and I was asking these questions to my professors, they were, seemed to be more focused on, well, how in a cerebral and an intellectual perspective. And I mention that because I think when I think of what makes a great building, it includes an aesthetic value that is uplifting and provides all of the essentials that we as humans require, but also is really focused on how does it impact us emotionally and psychologically, and not just from a physiological perspective. And I think it's irrelevant of what type of space it is, whether it's a home or an office space or, a large skyscraper. If those components are included in a cohesive format, I think that is what makes a great building.
Oh, that's a fantastic answer. Thank you for that, Tim. All right. Before we go, do you have any announcements, any exciting news that you'd like to share, anything you'd like to promote?
Yeah, thanks for bringing up my book. Both books are available on Amazon. I have a website that has links to my books and to also the ARXmed platform. So that's architecturalmedicine.com. And the other thing is the architectural medicine platform. It comes in two versions. There's a version that is focused on kind of the general public, those who want the information and can be provided with that education. And that is one facet of the platform. And the other facet is focused on the professionals. That's the ARXmed Pro of what I've, mentioned during the podcast. And that information is on the website right now. They're in beta. There's pilots testing the software, and I'm reaching out to others who are interested in giving me feedback. And if your listeners are interested, I will invite them to please reach out to me. And that information can be found directly on my website, architecturalmedicine.com.
Fantastic. All right, Tim, it's been an absolute pleasure. I'm so glad I finally got to have you on the show. Thank you so much.
Oh, thank you, Joe. It's been a pleasure and an honor. Thank you.
Yeah, you take care.
For you too. Bye-bye.
We hope you enjoyed this episode of Better Buildings for Humans. For more information on the world's best light diffusing and highly insulating glass glazing, please visit advancedglazings.com.